So good morning. I hope you all had a reasonable experience yesterday. It is for us at the center of our core values and at the center of our professional beings that we want to put on the very best program we can. And so I'm going to reprise something. Forgive me for those of you who were in the BA session yesterday, but I need to just share this with everybody. One of the ways that we're going to improve our business, you know, we are very young. We're 3 years old. We are learning by doing. And one of the most significant ways that we can bring to you the best possible program is to hear from you. Okay, you have in your packets an evaluation sheet. We would love to get feedback from you at the end of the week as to how the week went for you, what was clear, what was missing, what might we have spent more time on, and so forth. Because again, you know, we create this thinking that this is meeting your needs, but the only way we'll know that is if you tell us if we're meeting your needs. And that really goes for all of the courses that you're going to take. All right, I'll just share with you, online evaluations have just a terrible response rate. I mean, we've had in our courses responses from 2 people out of 40 on what they thought of the course. And part of the reason for that, of course, is because you're engaged all the while in sharing ideas and so forth. And so I think sometimes people feel like, well, I've already given my evaluation. Except that the university forces us to do a formal evaluation, and when we get 2 responses, we can't actually use it for anything. So I really, really encourage you, please help us be the best we can be by participating in the evaluation of the program throughout its duration. You will be doing yourselves a favor, and most importantly, you'll be helping out the people who follow you. Because we can think about how we're presenting our information and what we're doing in ways that will help us to be more receptive, more responsive to the needs of people in our program. Okay? So I'm appealing to you. I'm begging. I'm pleading. I won't get down on my knees. I'll just leave it there. What I wanted to spend a little bit of time talking with you today is about systems of health in Canada. And systems is really the operative word here. It is far too early in the day, to my mind, to try to bludgeon you with facts, statistics, organizational charts, and so forth. So I've actually chosen not to use any other materials and just to speak to you extemporaneously about systems of health. I want to begin with the whole idea of health. You folks are in a program, thank you, in which the core ideas of health, public health, and so forth actually have multiplicities of meanings and histories that kind of percolate up through lots of different places, lots of different times. And yet when we speak about it, we speak sometimes as though it's a flat, single idea, public health. So I want to tease that apart a bit and locate, first of all, the idea of health. What do we mean by health? Health is one of those very curious words in which all of us have an idea about what that means, but those ideas aren't necessarily universally shared by everybody else. It's like ideas of love and so forth. It's this great concept that people on the one hand understand, but the way that they understand it is a completely individualized thing. Now, clearly, against that individual expression, we do have cultural practices. Right? So we have ideas that surround notions of health based on where we happen to come from, based on the culture we happen to be born into or raised in. Well, if you think about the word itself, health, it has so many different kinds of meanings. Healing, right? Whole, balance, sound, even, level. All these different words that have nuances of meaning that really differ one to another. But somehow, adaptation, right? Some notion of being able to recreate everyday life in a way that is productive, sound, gives us the ability to do things, to act, right? To thrive, to aspire, to reach certain objectives. Notions of health more recently, through, for example, the WHO and so forth, ideas about health is a state of complete physical, mental, social well-being and not just the absence of disease or infirmity, right? A wonderful idea, but also clearly an ideal. What does it mean to have complete physical, emotional, social well-being? I don't know what that means, and I'll be perfectly honest with you. If that is the definition of health, I don't have it right now, because sitting in front of you and trying to explain what's on my mind makes me a little anxious. And that kind of erodes the idea of perfect physical, social, and emotional well-being for me. Right? Or the idea of health as a resource for everyday living, something we can draw upon in order to live our lives. So my point here is simply this, that the idea itself, health, is fuzzy. It's not easily contained. It's a word we can throw out and expect that other people will understand exactly what we mean. But that may not be true in a one-to-one correspondence. Now, if we add to it the idea that we fool ourselves, well, no, I shouldn't say that. I should say, living in a single culture might give one the impression that everybody has the same idea of health. But you think about the polycultural nature of our current society, right? Living amongst us are people whose family roots are scattered around the globe and whose ideas about lots of things, like health, differ from Western conceptions of what that might mean. And as you think about being a practitioner, I really hope that you will bear in mind that making assumptions about what other people think you mean by ideas that are bound up in health may be false assumptions, particularly if there are obvious cultural differences at play. Right? You may not believe in the four humors, but other people do. You might not believe in hot and cold ideas about health, but other people do. So as we move forward in professional development and so forth, I think it's important just to reflect on the fact that health is not easily contained. It's not an idea that's readily shared by everybody, and the probability of those ideas not being shared are exacerbated if you think about differences in culture. Right? And that's a difficult thing for us to be mindful of, because as we're teaching our courses, I'll just speak for myself, I often fall into the trap of thinking, well, everybody else is on the same page as I am, and they get the ideas that I'm trying to present. It's very difficult to be mindful of everybody in the world and all the ways in which things could be unfolding and so forth. That's a hard thing to do. We live our lives by actually not having to worry about that, by making assumptions about what daily life is going to be like and so forth. And so that's a very practical, wise strategy for us to live our lives in. But we just have to be reflective of the fact that sometimes that expectation of daily life might not actually be shared by other people that we encounter in our professions, in our daily routines, and so forth. So health is a fuzzy concept, not easily contained. Systems of health. What's the most important system of health that we belong to? What do you reckon? Our families, our loved ones, our friends, intimate others in our lives? That's kind of the most important system that we actually draw from, is it not? You think about those times when you're feeling blue, you're feeling alone, right? Depression, not feeling like you belong to anybody or you connect with anybody. I mean, it kind of reveals, it throws into relief those ideas about where the most important systems of health come from. they're really nurtured by those people in our lives that mean the most to us. They're nurtured by other things as well, clearly, by systems of economic relationships that give us access to resources, by the quality of the physical environment that surrounds us, and all of the things that obtain from that, the air, the water, the food we eat, the nature and quality of our physical environments. As Trevor will emphasize in his courses, we spend so much time indoors, and yet we never pay too much attention to the quality of our built environments. And in some ways, we might think about how that plays out in relation to the interaction between built environments and things like the obesity phenomena. Changing the nature of everyday life, becoming more sedentary. Add to that opportunities to consume more and more high or calorie dense but low energy and low nutrition food. Those are ways in which these reflections of our daily experiences actually register at the level of the population. So we start with you would have seen probably these constructions, these models of health that start with the individual, the family, and moving out in concentric rings into an ever larger sphere. And when I think about systems of health, I reflect upon that graphic because that is another way of representing it. Now, I can see I'm going to finish mighty early because I think I only have about 15 minutes left of what I wanted to give by way of an overview. And then maybe we can have just a conversation about some of these ideas. Public interventions, cultures, societies organizing themselves to try to maintain health and well-being are as old as civilizations themselves. Clearly, as human beings, our desire is to thrive and reproduce, But we might think, cynically, that life, for human beings, is a universally fatal, sexually transmitted disease. Right? I mean, in some ways, it's true, because that is exactly how we get here. And we didn't fall out of the sky. We've been around a long time through processes of evolution, selection, and so forth. Moreover, we're in it right now. It's just hard to imagine because those kinds of processes only really are revealing typically over very long periods of time. But societies, cultures everywhere have always intended to protect themselves, intended to employ what they would imagine being explanatory frameworks to ensure ongoing ability to thrive and survive. Now, some of those practices are reflected in, for example, religious beliefs about foods that can be eaten and foods that can't be eaten. They come to us in those ways. But if we think about formal systems of public health as we know them, while we have these echoes going back to ideas about water, food, sanitation, and so forth, it's really with the rise of modern populations and the changes in society that follow from that, the reorganization of daily life, the movement from, for example, well, first of all, you think about the rise of populations, okay? This whole stage was time we could walk all the way across and have almost no detectable change in population until pretty much the very last step that we take, in which case population does this, right? Think 16th century, 17th century. We know this from keeping of records, demography, and so forth. The rise of modern populations relates to a series of important changes that took place in technology, navigation systems, for example, exploration, the ability to find new resources, often, obviously, at the cost of the people who held those resources previously. Right? It changed the nature of access to food substance. Let me ask you a question. Where does the potato come from? South America. It comes from the Andes, right? I bet most of you were thinking Ireland. No? Maybe? The tomato must be Italian. Also from the Andes, right? That change of trade leading to incredible changes in diet, in opportunities to get nutrition and so forth, leading to greater survival rates of children, leading to changes in technology and the structures of society, that industrial revolutions, people leaving agrarian forms of life and moving into cities, industrial cities, cities that have no plans, cities that have nobody thinking through ideas of waste disposal, sewage treatment, regulation of food. All of those things that you might associate with modern practices of public health are really phenomena that coexist, that grow up in the context of the rise of modern populations and the rise of democratic societies. Regulations governing, for example, building codes. How close can buildings be together? Governing, for example, quality of water systems. You know, these are things that we are born into the world, and these things are already addressed. We just take them for granted. You turn on the tap, and you can anticipate that the water you're getting access to is potable water. Unless, of course, you live in a rural area, a remote reserve, or where your only access to water is groundwater that's contaminated by animal feces, or by mining processes, or by other pollutants. But for the vast majority of us, particularly those of us living in large cities, we never have to think about it. Flush the toilet, life is good. Turn on the tap, I've got my water. Those are all inventions, interventions, that are part of the rise of democratic societies. Now, so we've got this idea of public health. Now I really want to think about formal systems of health for a few minutes. Look, you think about the ways in which formal systems of care, that is to say, large explanatory frameworks about how the body works and the ways in which interventions can be mounted upon the body to cure illness or alleviate pain and suffering. Some of those systems are centuries old. I think of acupuncture, Ayurvedic medicine. Ironically, in the West, we refer to them sometimes as alternative systems. The real alternative system is a system that currently dominates, but is actually only 100 years old. Right? And that's a system of biomedicine. It wasn't until the 1910s that the Flexner Report came out. Right? The Flexner Report was commissioned by the Rockefeller organization to really think about regulating medical practices and putting the idea of medical practice into universities. All right? That's not to say that there weren't medical programs in universities more than 100 years ago. There were. They go back to places like Padua in in Italy and so forth. But the formal regulation of medical programs, the idea that people needed to get credentials and licenses to practice, and having a state apparatus to oversee all of that, is 100 years old. But it's a set of practices that currently dominates, certainly dominates the Western world, right? And it's a set of practices that most people believe are equated with the idea of health. In other words, health equals healthcare. And you think about that history and the ways in which that unfolding took place, okay? Now, formal biomedicine had colossal, well, let me just start with public health, because I preface that a while ago. Think about what public health interventions did. Bringing of clean water, the removal of sewage, the regulation of food and so forth actually was a colossal success in helping to alleviate pain, suffering, and disease. That was an amazing success. Some people refer to that as the golden age of public health, because systems of urban planning and so forth, of regulation on the part of the state, aligned with ideas of health and well-being as they were influenced by quality of food, air, water, and so forth. The alignment between those things started to diverge. So when we think about the incredible successes that took place toward the end of the 19th century, when vaccination started to be employed more widely, right? Great successes: smallpox, diphtheria, tuberculosis. Now, those successes are real, but you know, I would encourage you to just explore the work of Thomas McEwen, who wrote a book in the 1970s called The Role of Medicine: Dream, Mirage, or Nemesis, in which he shows that, in fact, the rates of death from infectious disease were plummeting in advance of the development of interventions against them. So, yes, we had BCG, I think it's called, the vaccination against tuberculosis. But you know what? That was developed after 90% of all tuberculosis cases had died off. Right? Most of those gains in infectious disease control took place not because of vaccination or inoculation, but because of changes in diet and daily life. And here's the hard part, I think. Because of those successes, and because it is a time of modernity, of exploring the world of science and rationality in new ways. You think about it. The automobile, the train, the telegraph, the telephone, all of these incredible interventions and new inventions that help to shrink the world, to collapse time, share information in ways that are just, again, thrown into the exponent by handheld devices that I bet every one of you has access to. At a time in which the promise of the future was in rationality, in science. Those incredible successes in acute infectious disease became the model for biomedicine. Build hospitals, train doctors, provide pharmaceuticals. That's the way to maintain health. Sadly, already the transformation from acute infectious disease to chronic conditions and multiple chronic conditions had already taken place. And yet, the healthcare system that we developed was based on that earlier set of ideas. Just think about it. The state doesn't formally start to intervene in health in Canada until, if we're talking about biomedical interventions, the state does not really intervene. It's a private set of practices and so forth until about the 1950s. Okay? Now, I'm going to pause there for a minute because I need to back up in this story and come to the other important moment of this and bring these things together. And that is, of course, the rise of the state. All right? I'll focus my attention on Canada. The Constitution Act of 1867 resulted in the division of powers between the federal government and provincial government. There was no legislation governing municipalities. That comes much later. In Canada, we might say that cities and municipalities are children of the province. Okay? And this is important to bear in mind because, again, I think about what Trevor said yesterday about his involvement in healthy cities, right? That in some jurisdictions, in Europe and so forth, cities play a very different role legally in the structures of state intervention from the roles that they have been mandated to play here. Doesn't mean that they're less influential in shaping health outcomes. It just means that they have fewer powers sometimes to be able to do those things. The Constitution Act of 1867 basically said that the federal government is going to be responsible for the following things: for security, for resource extraction, for overseeing agriculture, for those sorts of things that at the time were important to the Crown. Canada is, of course, what's it called? It's called a constitutional monarchy. All right? In other words, the head of state in Canada remains the Queen. Now, think about what that means, particularly if you are not from Europe or other places, but actually have your roots historically with peoples of North America. Right? Your traditional lands, everything is being governed by this figurehead called the Queen. Everything has to be signed off by the Queen. It gets royal assent. All laws are proclaimed by the Queen. Now, of course, the Queen does not, as you know, show up and do that. She has representatives, the Governor General and Lieutenant Governors across the territories and provinces. And those people are the Queen's representatives who formally implement laws that are created by democratically elected governments. So it is a symbolic kind of relationship, but it is the basis of our law. It is the basis of the division of powers and jurisdictional mandates. So the reason that this is important is because you need to be able to sort out those things that actually are a provincial jurisdiction from those things that are a federal jurisdiction, and indeed those things that might be of a municipal jurisdiction. Because in the case of public health, it cuts across all three. And it makes it a little bit confusing. So you think about who regulates food inspection, and so forth. That's the role of the federal government. So when listeriosis outbreak happens in Alberta, people wonder what's going on at the federal government because they've just axed half of the workforce of meat inspectors and so forth. What's going on there? That's a system breach. When we think about most of the services for public health, around, for example, management of addiction, mental health, or other kinds of issues, or think about home care, or think about lots of different ways, right? Public health nursing. Those are all structures of the province. In fact, the vast majority of services in the formal healthcare sector are provincial matters. We talk about a Canadian healthcare system, but that's really a fiction. It's a convenient label to describe what is actually the operation of 14 parallel systems held into place by a federal presence that puts money on the table to ensure that Canadians have access to care in keeping with the principles of the Canada Health Act. All right? Those principles are comprehensiveness, universality, accessibility, portability, and not-for-profit. Okay? The 5 principles of the Canada healthcare system. You can find this on Health Canada's website. So, all right, but be clear that you understand those systems, those structures, because what we've experienced in the past is that students in our program don't quite get the nuances of that. And when they're thinking about, in developing papers or positions on things, ascribing to one level of government that which it has no jurisdiction over, right? So the federal government should do nothing about hospitals except in a backdoor way or in a backroom way of putting part of the money on the table that helps to support those hospitals. Hospitals are provincial concerns, with very few exceptions. The feds do play a direct role in, for example, Aboriginal peoples on reserve, Inuit, for veterans, for federal prisoners, and for some refugee groups. So it's not as though the federal government doesn't play any role in the delivery of health care. It's a very limited role. Most of the meat and potatoes of the system runs through the province. And that's just something that you, if you don't know already, you need to be aware of. And as I say, you know, there are lots of different books that talk about the formal organization of the healthcare system. I don't want to get into all the nuances of change and so forth, but there are a couple of important moments in the development of that. Again, this is a relatively recent phenomenon, right? This has happened pretty much within my lifetime, and I'm 58. Right? The Hospital Insurance and Diagnostic Services Act came out, I believe it was 1957. I was 2 years old. That act was a federal act that said we will pay for all healthcare services obtained through hospitals. Right? We'll pay for those services if they're provided in hospitals. Well, just think about the impact of that. Okay, I'm a struggling farmer, and I'm trying to figure out, let's say I feel a little bit sick. Should I go to see the doctor, or should I go to the hospital? If I go to the hospital, it doesn't cost me anything. If I go see my doctor, I got to cough up 2 chickens. Maybe I'll go to the hospital. Think about the way in which that impacted our culture. Suddenly, if you need services and you don't want to have to pay for them, go to the hospital. Hospitals are the most dangerous places we have, for God's sake. But we have this culturally conditioned idea that hospitals are the place to go if you're sick. And that's a hard nut to crack. That's a hard thing to change in people's minds. Right? The province of Saskatchewan then led the way to say, wait a minute, this is crazy. We should make services available to everyone, whether it's in a doctor's office or in the hospital. We should just cover those. And a few years later, that's about 1962, by 1965, there's a federal commission, the Hall Commission, looking at should Canada adopt a formal health care provision. You know, make the access to health care services free, or at least some portion of them free. That portion that was deemed to be necessary. And so if you look at the first round of what became the Canada Health Act, it says all necessary health care services will be free at point of consumption. You don't have to pay to get the care. Okay? Very, very cool idea. What's the definition of necessary? What's necessary? Who the hell knows? But you've got organized professions and you've got companies developing things that argue. Well, this is necessary. Well, of course that's necessary. Well, that's necessary. Everything's necessary. Constant pushing the boundaries. What's necessary? All healthcare is necessary, isn't it? Isn't it? Well, turns out, of course, it isn't. Some of it's downright dangerous. Iatrogenesis, those things that kill people as a consequence of encounters with the healthcare system, C. difficile and so forth, that we are experiencing today. And medical malpractice, errors, and so forth are all things that happen as a consequence. Now, look, I want to be clear about this. I'm not trying to hit on doctors or the healthcare system. I'm trying to be frank with you about the predicament that we're in right now as we think about moving forward and what we're trying to accomplish. We've institutionalized a system that equates health with healthcare. We've created all kinds of incentive for that to be focused on a formal healthcare system involving doctors, hospitals, and ancillaries, in a system that was built for infection control at a time in which we live our lives trying to deal with chronicity. That's crazy. So today, in the mid-1980s, there was a revisitation of this, and the Canada Health Care Act was declared by Monique Bégin, the then Federal Minister of Health in a Liberal government in 1984. Re-enshrining the 5 principles of Medicare, and also giving penalties to provinces for any extra billing that went on. In other words, if physicians tried to bill a patient beyond the rate that had been negotiated between the doctors or others providing the service and the province, then the feds would withhold that equal number of funds from the province, so the province would have to pay. Trying to give incentive to the provinces to get rid of extra billing, to get rid of fee for any sort of add-on around services that were provided. Today, we live in a Canada in which systems of health, in the public imagination, is the healthcare system. It's the healthcare system. Analyze any provincial election, and it is rare that you will not see healthcare as the #1 issue. It's rare. And if healthcare is not the #1 issue, damn it, it's going to be #2. Right? Think about the regime we're in now federally. We have a federal government that has really decided to adopt a stance of what is called classical federalism. In other words, if I go back to the Constitution Act of 1867, remember I said that the provinces were mostly responsible for healthcare and other things, education, social welfare, and so forth, housing. In the 1950s, in the 1960s, and in the 1970s, through to the 1980s, the federal governments played an active partnership role in the provision of health services. While they did not deliver the bulk of services directly, they cost-shared them and had a big stick to try to ensure that all of the jurisdictions played together nicely. Right? It was an active engagement. This regime has said, here is the money for health care. We are not attending a First Minister's meeting. We're not going to negotiate with you at all. We're putting this money on the table. You fill your boots and do what you want. For many people, this makes them very, very uncomfortable because, notwithstanding the things that I've said about the craziness of our healthcare system, it is a core Canadian value. How do we define ourselves as Canadians? All right? You think about who is our biggest comparator? Always, it's the United States. I mean, think about it. The United States of America, the most powerful nation on earth. What do they have? They have as their symbol the bald eagle, an apex predator. What is ours? It's a rodent. You know, a beaver. You know, there's Sylvester Stallone. We as a nation are Woody Allen. But, damn it, we've got health care and gun control. Take that. We're just like you, only better, because we've got those two things. It means a lot to Canadians. It means an enormous amount to Canadians. And again, therein lies part of the difficulty that we're faced with. Because on the one hand, how do you sort of stand against that cultural value of the idea that we care for one another? The idea that we won't be bankrupt if we get sick. You know? The idea that we share the risks. Those are important cultural values to hold. But if we look at the ledger of how we understand health and what shapes it, poverty, And what's happening to rates of inequality around access to income in this country? I can tell you what's happening. It's going in the wrong direction. Think about quality work, work that's meaningful, right? Finding opportunities to be engaged in the world in ways that stimulate you, that make you feel good, that make you feel needed, right? That make you feel like life is really great and I love it. I love my job. I like doing what I do. I'm proud to tell people I am a boom. I do this. I do that. Think about how that works in shaping our identity. And then think about going to a party and saying, I'm a drug addict. I'm homeless. Oh, yeah, I work in the sex trade. Things that often don't percolate to the top of the list of noble undertakings. Identity. How we explain ourselves to the rest of the world. Our ability to control our everyday environments, to make choices. Our ability to at least participate in the great parade of life and not just sit on the sidelines watching it go by. Everybody else gets to have a vacation. Why can't I have a vacation? Everybody else gets to have the latest nano or whatever. How come I can't do that? Those are things that are corrosive to our human spirit and indeed to our biology. And we know that now. Right? We know that it isn't, that there's a relationship between our social being and our biological responses. Things that the healthcare system formally can do almost nothing about. Think about it. Go to your doctor next time and say, actually, I'd like you to write me a script for more income, please. Oh, a more loving relationship. Yeah. I just want a better identity. Can you give me one? Make my loving relationships with my spouse or my intimate other more loving. Can you do that for me? Clearly, you can't. So we're caught in this conundrum here. The factors that shape health have really largely not a lot to do with the formal institutions that we think are about health. That's crazy. And that's the challenge that we face. That's the challenge that we face. How do we create a discourse in which we can manage those changes and make investments in the things that we know actually improve health? And how do we do that in the face of now trying to erode the power of the most powerful professions in our society? I don't have a hurt on for doctors. Actually, I'm a doctor. I'm just not a medical doctor. Right? Well, it's interesting too, you know, in this country, medical, MD is actually an undergraduate degree. But maybe that's nitpicking. So I'm going to conclude here, and then maybe we can just have a discussion. My diatribe this morning, and I hope it hasn't been too painful, has been trying to connect in a free-flowing way a set of dots. What do we mean by health? Where does it come from? How is it understood in a global context? Well, lots of different ways. What are the formal structures that are in place to try to ensure health and public health? Well, some of them are old and are parts of traditions that have been with us for a long time. Some of them are relatively new as a consequence of the changes of the structures of everyday life that have taken place, really, since the 16th, 17th century. The rise of what we might think of the democratic state. And then the local state, you know, provinces, municipalities. Some of them relate to the formal organization and architecture of a system that we've put into place that we contribute to mightily, about 43 cents of every public dollar that we have. And that doesn't cover all the costs, by the way. That's just the public. You know, you pay out of pocket for a lot of stuff. A rising understanding of, through social epidemiology and biological sciences, of what actually is going on to shape those health experiences. The rise of chronic diseases, replacing infection as the dominant diseases of our time. And structures that have difficulty coping with that, and structures that have enormous difficulty in preventing, in promoting health and well-being. And you are in a program in which that's the mission. How do we prevent and promote? How do we prevent disease, promote health and well-being? How do we create public policies that actually wisely deploy resources to maximum benefit? You know, this province, 1 in 5 kids grows up in poverty. Yeah? I think a really interesting lesson in how public policy can work is I invite you to just look at what happened to rates of poverty among children and among seniors since the end of the Second World War. All right? We as a country made a very clear decision that our parents were not going to end their lives in poverty. They had worked hard. They had experienced 2 world wars and a depression. And damn it, we were going to do something about that. So we created old age security. And the rates of poverty among seniors started to plummet. And that's a very positive thing. Unfortunately, what we haven't done is thought about children. And the difference between seniors and children, of course, is one is sunsetting in life and the other is emerging in life. And that sunsetting has already experienced all those factors that have led to a particular kind of health outcomes that result at the end of life. But those people who are emerging still have that story to be written. And yet we don't have the sensibility to think about how we can manage that. It seems like we're okay. As long as it's not our kid who's poor, it's okay. Those are some of the fundamental challenges that we face, okay? So I hope, I just want to leave you with the idea that in the program that you're in, you need to, A, understand the formal and informal structures that are at play, and be clear as to, particularly in the formal structures, what their jurisdictional provenance is. Who is responsible? You're in a situation in which really it's chronicity, not infection, although I don't want to say infection doesn't exist, but in relative terms to the history of human experience, where chronicity is the most important issue that we're faced with. And where we've created public institutions, sadly, that are rooted in a different kind of conception about what the big issues are. We've created, in the forming of modern democracies and what we might call the welfare state, and the welfare state is not a pejorative term. I think it's the most positive term we could use. It was the way in which the state said, we're going to take tax dollars, we're going to spread money around to ensure that everybody can participate in our society. And we thought that the way to do that was to create hospitals and a healthcare system. We thought the way to do that was to create a public education system, right? We thought those were key strategies to really develop this moving forward where we care for each other. At a time in which our analysis tells us maybe we were a little bit wrong. And how the hell are we going to change this? What are we going to do? What can we do? And I'm afraid that's going to be your challenge. And I hope it doesn't scare you. It's a marathon, not a sprint. And I wish you all the best in that journey. Thanks for listening. I appreciate that. Thank you. We do have a few more minutes if there are questions. Yes? Sure, okay. So I'm just going to repeat your question because it's being taped. So the question is, can I just talk a bit about the changes that happened in the 80s and 90s in the healthcare system? In the relationships between the federal and provincial governments. Happy to do so. So let's just cast our minds back to what was happening in the 1980s, okay? Remember, deficit and debt. Deficit and debt were the two key words because at the time, the financial prospects of the country were threatened by the fact that interest rates were high and that servicing the public debt was also a great challenge, because now suddenly 20 cents on every dollar is just going to pay interest. Right? And think about that in contrast to today. We've had enormously, historically low interest rates for a long time. So, and secondly, in the 1970s, of course, the government issued a white paper called A New Perspective on the Health of Canadians, right? The Lalonde Report, which actually was the forerunner of what we might call health promotion, right? The idea of the sort of fourfold factors that shape health, right? There was lifestyle, there was environment, biology, and healthcare, right? So the notion at that time that was being signaled actually was health does not equal health care. This health field influence actually had to be thought about, because it turned out the state recognized that we can't sustain this level of investment in a healthcare system. We've got, on the one hand, this exuberance on the part of the public for healthcare. We want more, everything's necessary, give us more. And in the 1960s and 70s, when economic fortunes were pretty good, think about it, this university created at exactly that time. Right? Simon Fraser University, University of Calgary. You think about the building of public institutions across this country that happened in that post-war era, 1960s, 1970s, Lester B. Pearson giving way to Trudeau and so forth. This country had money. Economies were thriving. You could build hospitals, you could build schools, universities. But as the economic fortunes changed, those pressures were still upward. And so the government decided, okay, we're going to create a different kind of agreement. We're going to, instead of it being a 50-50 cost share, we'll give you 50 cents we'll give you $1 for every dollar that you spend in health. We're going to change this formula. We're going to give you less money directly, and we're going to give you some more tax points. So in other words, instead of us giving you dollar for dollar, we'll give you, say, 40 cents on every dollar that you spend, but you can get that 60 cents difference that we used to pay through taxing people. So we'll give you those tax points. All right? There was then a series of, okay, wait a minute, we can't afford this, we can't afford that, we're going to delist this, we're going to delist that. Some professions are no longer going to be recognized. Midwifery. We're not going to do in-school public health nursing. We're no longer going to pay for eye care unless you are nearly blind or have certain kinds of conditions. But we're not going to just let you go see your optometrist and figure out whether or not you need glasses and so forth. That's over to you. We're not going to pay for dentists. We're not going to pay for audiologists. We're going to stand back from some of those things. Right? So with successive agreements then, what the state tried to do is to say, so the Health Accord of 2004, all right, here's the money for the provinces, but we want you to do certain things better. We're going to give you this money, but you need to better manage wait lists. You need to do a better job on various other things. Okay? So that's kind of what happened over that period. It was a period in which the fundamental principles of the agreements between the federal government and the provinces in sharing around health care services was renegotiated somewhat. Not changing the fundamental principles of universality, not-for-profit, portability, comprehensiveness, and accessibility, but renegotiating the fee structure around that. Well, today we're in a situation where the federal government is really just taking a hands-off approach completely and just saying, here's the money, fill your boots. You guys duke it out, figure out how you're going to manage your system, figure out what you want to do, and so forth. And, you know, again, if we think about what I was saying earlier about the organization and so forth, maybe this represents an opportunity, because maybe some of the changes that we really should be thinking about implementing with respect to state intervention, taking some of the money we put in healthcare and alleviating child poverty, creating housing systems that work for people and so forth, maybe there's an opportunity there. On the other hand, There is an anxiety about that because you think about this country. This country I think it's a miracle that we have a country at all, to be honest. I mean, think about it. PEI, being at the same table as Ontario. PEI isn't, the whole province of PEI, the population, doesn't even represent a small town in Ontario. And yet, they're equal partners in the Federation. Think about the vast distances of the North, trying to be part of an equal federation. Think about the unevenness of resources as they play out across this vast land. And yet trying to create a place in which the Federation can work. I think, so on the one hand, the current regime and the sort of immediate future may present certain kinds of challenges of, well, is there an opportunity to repackage and so forth. On the other hand, it deeply threatens the fundamental fabric of who we are as a federated state. And I think those are huge challenges for us. And I think, again, if you listen to some of the debates and discourses that go around on that, you're going to hear people really present very different points of view on that. And one other thing, I haven't said it all yet, but I need to say this. If you think about employment prospects, those institutions in the healthcare system, hospitals and related kinds of facilities, are enormous employers. In many, many places, the largest single employer in the town. So it's one thing to say, how do we change these institutions, these structures? But it's another thing to face people who are working in those structures, who make those their livings from those structures, and say, well, actually, you know what? Made a big boo-boo about 80 years ago. Sorry, we're going to close this hospital. Hope you can find a new job. Why don't you just retrain yourself? You know, you must be good at something else. I mean, those are very, very, very difficult things to do. And so anyway, I hope I answered your question in a not too rambling fashion, but it, you know, it speaks to, yeah.
In the limited time that's left, I'm wondering if you can expand on the impact of the transfers moving forward being tied to economic growth or lack thereof.
Yeah, it's a very good question, and I really don't know if I have an answer for you. I think it is emblematic of the ways in which values play out within a conservative ideology around, okay, the market should determine, you know, success, right? Those people on the left, they're all bleeding hearts who think that we all got to take care of each other and, you know, make sure that nobody's... It robs us from incentive. It robs our ability to pull up our socks and get out there and do things for ourselves. And that's what we should be doing, right? So it seems to me it's not a very, I think, promising answer or direct answer to your question, but I think it's more reflective of the value positions that people on that part of the ideological spectrum hold. Right? And please, I say that in no way trying to be pejorative or anything else. We all inhabit different parts of a value system. Okay, and so I'm not for the moment saying they're bad people or they're wrong. They just have values that say we need to incentivize. The market is the way in which incentives get distributed because the market represents people's participation and action in an arena, and that's what we want. You know, and I can contrast that with something in which, you know, the state provides everything. And we've seen models of that in the past, of, you know, failed experiments around food production, for example, or state industry, for example, in which these sort of ideal notions of equity or equality, of sameness, of, you know, universal solidarity, have their own problems and really rob that incentive. So I think that's kind of how that, the backstory to that kind of stance, to that kind of trying to incentivize is based upon those value propositions that those people who are currently constitute the federal government hold. Okay. So I hope that's okay. And I see that we're out of time. Again, I want to thank you so much for your attention. And let's go. Thank you.